So we're going to talk about atrial dysrhythmias. So atrial dysrhythmias are dysrhythmias that arise in the atria. The first one we're going to talk about is your AFib. Now, if I'm doing the 5-step method on the AFib, the first thing that you look at is the rate. The rate is going to vary with AFib. And so that's one thing that I can't tell you. It's always going to be between this number and that number, because that's just not accurate. It varies. The other thing you're going to look at is your rhythm. Your rhythm in AFib is very irregular. The third step, remember, that's when we look at our P waves. When you look at your P waves, what you will see is you have no clearly defined P waves. When you look at it, you see that you would just have a very chaotic rhythm, and there's no clearly defined P waves. When you look on this strip right here, you really can't tell me where your P waves are. Okay, so remember, the fourth step is we look at our PR interval. When you look at this strip right here, remember, if you don't have a P wave, you can't measure a PR interval, so it's not measurable. And then the last step is we want to look at our QRS complexes. When we're looking at our QRS complexes, what we're looking for is we're looking to make sure that these QRSs are similar in appearance and that they're within defined limits, and they are. So that is the 5-step method for your AFib. When we look right here, the first thing we want to look at, because we'll just practice on this one, is your rate. So remember, to get your rate, you count the number of complete QRS complexes that you have. So we have 1, 2, 3, 4, 5, 6. So remember, you take 6 times 10, and that's 60. So the rate for this individual, for this strip, is 60. So then the second thing you look at is you're going to look at it and tell, is it regular or irregular? Now, it's not really hard to look at this strip and tell that it's irregular, but remember, what you're looking at is you're looking at these R's to R's to see if it's the same, and you can clearly tell that they're not. So this is irregular. Then what you do is you look for your P waves. And so when you're looking for your, you remember, your P wave is before your QRS. And as you can see, you can't tell me that these are P waves. They're not clearly defined. So I don't have P waves. All I have is, it looks kind of like I have a lot of squiggly lines between my QRSs. AFib is a very ugly strip. And then the last step we look at is we want to look at these QRS complexes. When you look at these QRS complexes, like I said a little earlier, we want to make sure that they're similar in appearance and they're within defined limits, and they are. So this is what AFib looks like. AFib is the most common dysrhythmia that's found in practice. We currently have more than 2 million Americans that walk around in AFib and do not know they have it. And the reason that is they probably have a controlled rate. So rates that are below 100 are called controlled. So they have a controlled ventricular response. So they're probably not going to have any signs and symptoms. If they do, they're very minimum. However, if someone has a rate above 100 beats per minute, what we call that rapid ventricular response. And so that person is going to have signs and symptoms associated with atrial fib. So those signs and symptoms they're going to have, they're all going to be related to decreased cardiac output, because our major issue with AFib is that we don't have P waves, so that patient loses the atrial kick. So maybe you remember your atrial kick from A&P, but the whole purpose of the atrial kick is it allows for a greater cardiac output. So these individuals lose that. Now, some of the risk factors for developing AFib, one is just age. As we age, we are more likely to develop this. But some other things that can happen, one of the biggest risk factors is hypertension. And then we have diabetes, and we have any type of valve disease. Cardiac surgery, this is very common. Actually, this is the most common rhythm, or I should say dysrhythmia, that a patient experiences following cardiac surgery. Also, if someone has congestive heart failure, they can experience atrial fibrillation. So those are just some risk factors for developing AFib. So remember, I told you your signs and symptoms are going to be related to decreased cardiac output. So when you are talking about AFib, the first thing you always want to do is you want to verify it. In a stable patient, you always verify with the EKG. Now, the other thing you need to remember about AFib is someone could have something we call chronic AFib, or they could have intermittent AFib. So chronic AFib means they just are always in AFib, but intermittent AFib means that they come in and out of it. So they might be normal sinus rhythm, and then they have a run of AFib, and then they go back in a normal sinus rhythm, and then they have another run of AFib. It's just very intermittent. So those symptoms they're going to have, guys, it depends on how fast their rate is. As I told you earlier, if their rate is less than 100, they probably do not have a lot of symptoms. If they have symptoms, they're very mild. However, once that rate jumps up past 100, that's when your person starts having some of those symptoms that are listed here. They get very pale, they get very dizzy, they start complaining of shortness of breath, they become hypotensive, they have lots of fatigue, and they complain about weakness. One thing you need to make sure that you, or I should say you are very aware of, is that they are at a risk for a systemic emboli. So you want to make sure and assess for any type of changes in their mental status, their level of consciousness, their speech, any of that stuff you want to look for, because remember what's happening is in AFib, your ventricles, they're doing their job and they're just a-pumping like they should, but the atria, instead of pumping, it's just quivering. And so as it quivers right there, the blood pools. And anytime you have a pooling of blood, you have an increased risk for a clot. So if that clot makes it out of the ventricles, it goes to the body, and wherever it goes, that's what it becomes. So if it goes to the brain, then the person has a stroke. If it goes to the leg, then they have a DVT. If it goes to the heart, then they have an MI. If it goes to the lung, then they have a PE. And so they're going to start having those signs and symptoms. So people that are on that have AFib, they need to be on some type of blood thinners, and it has to be more than just an aspirin, guys. Okay. Typically, we start aspirin on individuals once they reach a certain age. That's just kind of the standard practice. But in someone who's in AFib, they need something more than just an aspirin. There's lots of drugs out there, and so the biggest thing you can take away from this is if you admit a patient, or if you have a patient that's in AFib, you want to look at their med list and see if they're on any blood thinners. If they're on aspirin, that's great, but then look and see what else they should be on, because they should be on something else, because they are at an increased risk for an emboli. So if someone's in AFib, we have some interventions we're going to do. Of course, we know they don't have enough circulating oxygen, so we're going to give them some oxygen. Other things we will try and do, we're gonna try and convert them through medications. Our whole goal in AFib is to convert them back to normal sinus rhythm. That's our whole goal. We start with medications. Typically, we have to start with IV medications, so we'll give DIG, we'll give beta blockers, we'll do calcium channel blockers, because we are trying to slow the heart rate. If that doesn't work, other options we have, we can do something called cardioversion. I posted a little link here for YouTube so you can go and watch cardioversion, but that is an option. And essentially cardioversion is just where the healthcare provider goes in and delivers shock to the heart in the hopes that when you shock the heart, it pauses or it stops temporarily, seconds. And the thought process behind that is it stops and then it's going to start back, and it's going to come back into normal sinus rhythm. So I like to think about it, if I wanted to compare it something, think about when your computer doesn't work and you get frustrated and you tried everything and then it still's not working, and so you just unplug it. You kind of reboot it. Well, that's what cardioversion is. It's just for the heart. We're trying to reboot the heart. And most of the time that is successful. Sometimes it's not, though. And then we might have to try something else. So we can do something that is called a catheter ablation, and that's where we go in through a major artery, we go to the heart, and we try and determine what area in the heart is causing the electrical conduction issue, and then we just, they have a little tool and they just cauterize that area. And their thought behind that is, well, if we get rid of that area, they're not going to have all those irritabilities in the atria, and they're not going to be in AFib. If that doesn't work, we can do something called a maze procedure. So a maze procedure is where we actually open them up, we spread their ribs, and we look for the area that's causing the irritability, and we try and get rid of it. So these are all interventions. However, realize that sometimes we've tried all these and they just don't work, and that patient just is in AFib. So if that's the case, if we tried all these interventions and the person still continues to be in AFib, what we do is we just make sure that they're on blood thinners, and then we also want to look at rate control. We want to control the rate. We want to get that rate less than 100, because if we get the rate less than 100, then their signs and symptoms should go away. So that's your whole goal in someone who has AFib. So the next atrial dysrhythmia I'm going to talk about is a flutter. So I always like to do the 5-step method, so let's do the 5-step method on a flutter. Your rate is going to vary. There's not a tried and true number I can give you for rates. Just realize that the atrial rate, so your atrial rate, that's like what your P's are doing right here where my mouse is. Your atrial rate is typically between 250 and 400 beats a minute. That's a lot. We call these flutter waves. Okay, so your rate, your atrial rate, 250 to 400 beats per minute. Your ventricle rate, meaning that's what these QRSs right here, because remember your QRSs show what's going on in the ventricle, they're going to be slower. Okay, so your atrial rate and your ventricular rate, they don't match. Your P waves, you don't have normal P waves. As I've told you, you have these flutter waves right here. Okay, so if you don't have a P wave, remember you don't have a PR interval, so you can't measure one. And then when you look at your QRSs, they are normal and within defined limits. So those are your characteristics of a flutter when you're doing the 5-step method. So some things I always like to talk about with a flutter. Remember in a flutter, the AV node, it blocks the number of impulses that actually reach the ventricles, and that's as a protective mechanism. Because if you have an atrial rate, let's say 250, and all of those impulses went to the ventricles, then that means that your ventricle rate would be 250 beats per minute. A person cannot maintain at that. So it's a protective mechanism that's going on here. Some things that can cause a flutter, I listed some of them for you. Of course, CHF, any type of valve disease. The person could have a PE, or they could have ischemic heart disease. Another one, they could have had an MI. They could have pericarditis. This often happens in pericarditis, or they could have alcoholism. So you will see this A flutter in alcoholism. So these are all things that can cause AFib. Here's another great example of atrial flutter. Okay. So again, remember in atrial flutter that you don't have normal P's. What you have is you have these flutter waves. Okay. So these right here are flutter waves. Let me go back one right here. Right here. See? A flutter, you have these flutter waves. So if you're trying to compare between AFib and A flutter, what you need to think about is A flutter is your pretty dysrhythmia. You see how pretty this is? Okay. And then let me go back and we'll go to AFib. Now look right here. Okay. So AFib is kind of your ugly atrial dysrhythmia. See how you just kind of have chaos between your QRSs? You just kind of have some junk in there. So that's when I'm trying to tell the difference between the two. That's always a tip I like to give people is your AFib is chaos between your QRSs. Your A flutter are these nice pretty flutter waves between your QRSs. Okay? So again, in A flutter, you have lots of things that can cause it. CHF, alcoholism, pericarditis, MI. Okay? Again, right here, this is another prime example. So let's do our 5-step method on this because we can always need some practice with that. The first thing you're going to look at here is you're going to look at your overall rate. So you're going to count the number of complete QRSs. So when we count the number of complete QRSs, here's 1, 2, 3, 4, 5, and then there's 6 because it comes back to baseline right there. Okay, so 6 times 10, that's 60. So my rate is 60 right here. The next step we do is we look to see if it's regular or irregular. And what you see here is that it is regular. Okay? Then you look for P's. Guys, you can't find any P's in here. You have these flutter waves. So if I don't have P's, remember I can't have a PR interval. And then the last thing we look at our QRSs. When you're looking at your QRSs are within defined limits and they're all similar in appearance. That is your 5-step method for your A flutter there. So again, as I told you with AFib, with A flutter, you want to verify with an EKG to make sure the patient is actually in A flutter. The other thing I always like to tell you is if you have someone, I'm going to go back here and show you, if you have someone that is in A flutter and it's nice and pretty and regular, and then all of a sudden it starts turning, their rhythm starts turning irregular, what that means, it means that patient is about to convert to either AFib or they're going to convert to an AV block is really what it's telling you. So just be on the lookout for that. Again, your symptoms, they're going to depend on what the overall ventricular rate is or ventricular response. The main thing we're worried about here with A flutter is we are worrying about decreased cardiac output. So guys, the symptoms you're going to see, they're decreased cardiac output. They're all related to that. Your patient's pale. They have shortness of breath, fatigue, weakness, anxiety. All of those things that they have with decreased cardiac output, you're going to see here. What you need to remember is those clinical manifestations, it is going to be dependent on whatever this ventricular response is. So if you have a ventricular response of 60, you probably won't see too many of these signs or symptoms. But if you had a ventricular response of 160, you would see a lot of these signs and symptoms right here. So our whole goal in A flutter is we need to try and convert them back to normal sinus rhythm. That is our goal. So ways we try and do that, we try and do that through medications. Medications that we will give for A flutter, we will give DIG, we will give beta blockers, we'll give calcium channel blockers, because again guys, all those slow the heart rate, and that's what we're trying to do. We're trying to slow everything down. However, be careful with your DIG and your beta blockers and even your calcium channel blockers because they can drop your blood pressure. So make sure you check your blood pressure before you give those medications. Remember, other things that we want to do. We can do the cardioversion just like we did in the AFib. We can also do the catheter ablation. Your interventions for that are the same as they are for your AFib because atrial fibrillation and atrial flutter, they're both atrial dysrhythmias, so we treat them the same. Okay, so I want to practice a little bit. So I'm going to give you probably 30 seconds to look at this, and we want to do the 5-step method, and I want you to tell me or look at it and think about, because you can't tell me obviously, but think about what this could be because we're going to do the 5-step method. Okay, so the first thing we're going to look at is we are going to look at what is my rate. So let's see. Okay. 1, 2, 3, 4, 5, 6, 7. 7 times 10 is 70. So my rate is 70. Then I want to look and see, is this regular or irregular? So you look at your R's. Okay? When you're looking here, look at this. You clearly see that this is irregular. So then we're going to look at our P waves. Okay? I don't see P waves. I mean, there's a P wave, that one right there, but that's it. And then right here, obviously this is where this person's rhythm has definitely changed because there's no P, there's no P, no P, no P, nope, no. So okay, so I don't have P's, so I can't measure a PR interval. And so when I look at my QRSs, here's our QRSs. Our QRSs, they're all similar in appearance and they're within defined limits. And so now that in the 5-step method, I know if I have something wrong with my P waves that it is a atrial dysrhythmia and I only have 2 atrial dysrhythmias. So this one is irregular. So, and the other thing, remember I told you it's very ugly, it's very chaotic between your QRSs. So this is AFib right here. Okay. So let's try this one, guys. I'll give you just a minute to see what you come up with before we go over it. Okay. So the first step, remember, is we are going to find out what the rate is. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay? So our rate's 110. So then what we're going to do, we're going to look at our R's right here, and they have these 2 R's marked for you, and we're going to look to see if it's regular, meaning our R to R's are constant. So we look there, we're comparing, and what we compare is that yes, this is regular. So our third step is let's look at our P waves. Okay, well that's my first clue, is I don't have P waves. I have these flutter waves right here. Okay? Well, if I don't have clearly defined P waves, then I can't have a PR interval. And so the last step to do is to look at my QRSs. When I look at my QRSs, they're within defined limits. So that tells me that this right here has to be a flutter. Okay?